Hello, everyone. I'm Hyeon-Cheol Gwon from Samsung Medical Center, and I am delighted to participate in TCT virtual symposium. I am co-chairing with Dr. Andy Wai-Kwong Chen. Can you introduce the session for us?
Okay, thank you, Dr. Kwong. We have the three panelists in this section. Sorry if I mispronounce your name. Dr. Vorarit Lertsuwunseri, and Mohammad Mohsin, and Dr. Yasunori Ueda. So I would like to start with the first, introducing our first speaker. Our first speaker is Naoki Shibata from Nagoya University Hospital, Japan. And the topic is our experience of cover stent implantation for saphenous ring graft Peri-stent contrast staining. Dr. Shibata, please.
Yes, my name is Naoki Shibata from Nagoya, Japan. Today I'd like to talk about our experience of covered stent implantation for saphenous vein graft Peri-stent contrast staining. She was 52 years old female. In 2013, due to severe AL, mental and hemi-arch replacement was performed. And at that time, she was diagnosed as aortic syndrome, so PSL was started. But after 2 years, due to a false aneurysm, she had coronary artery reconstruction using SBZ, this site. And before discharge, we checked graft patency via MDCD. This is her baseline. She had her home medication shown here. But 6 weeks after discharge, she had recurrent chest pain, and because it got worse, she came to our ER emergency department. They prepared emergency CAD, but before that, she had ventricular fibrillation at ER. So an emergency CAD was performed with CPR. After studying VA ECMO, ARG showed a total occlusion of SVG from ostium. Angiography and IBUS showed severe coronary stenosis from the ostium site, like this. So we did the PCI. After Vorarit crossing and balloon dilatation, we implanted the ES stent. And final IBUS and angiography showed good stent expansion from here to here. But this is the time course figure after the first PCI. This blue side was I now explained, but after a half year, she had chest pain again and less stenosis at LMT site was observed. Then we choose the CABZ and data to LAD, SBZ to PL. But unfortunately, CTTA at discharge elucidated severe stenosis at data LAD anastomosis site here. So second PCI was performed. However, as you can see, she had recurrent coronary stenosis every half year from 2016 July to 2020 March. She underwent PCI eventually 7 times at mainly MMT lesion. We did the stent implantation and mainly used DCB, but the coronary stenosis could not be stopped. And furthermore, angiography showed an advanced PSS expansion from here to here. So to prevent the advancing PSS and worsening cardiomyopathy ischemia, this time 8 times, this time we decided to implant the covered stent. After guiding Khaled was engaged, angiography showed a significant instant stenosis at SVG's proximal site and a remarkable PSS. After pre-ballooning with a cutting balloon, we evaluated this site via IBUS and LCT. This is only IBUS imaging. After using cutting balloon, the stenosis was resolved, but as you know, as you see, the significant PSS was still remain, of course. So we use the coronary covered stent, but unfortunately, the stent length at SBZ region was too long to the perfect coverage with one stent. So we implanted the graft master from SBZ ostium site. So this is final angiography, and this is IBARS imaging from this part. Here is probably the LMT lesion, and here is already, here is already SBZ. And this is implanted EES before this session. And here is a covered stent site. So as I said, sorry, I skipped this one. So, and this is ostium site. So as I said, the length is a little bit shorter than the PSS lesion. So here is just one point we couldn't cover the PSS site here. And this is OCT imaging. Here is in the covered stent site. Yes, this is the key slide of my presentation. We implanted EES at the SBZ region, and after 2 years, the significant PSS was checked. So we implanted coronary covered stent. As you know, aortic syndrome is rare syndrome, and we basically use the PSL or some medication. And it is important to use SBZ rather than some aortic graft. And the PSS is sometimes observed after DES implantation for coronary artery. And this is associated with late stent malposition. Although PSS is considered an abnormal coronary artery wall response to antiproliferative drug released by DES, staining after DES implantation in SBZ is there. So I'd like to conclude my presentation. We experienced the gradual expansion of PSS in the SBZ lesion. We eventually implanted a covered stent for this lesion to prevent the prognosis of PSS, but other option might be considered at each point. Thank you for your listening.
Okay, go ahead, Dr. Chen.
Okay, any questions from the floor?
I have one question, actually. Yes. So this lesion is repeatedly restenosed and multiple. You did performed a lot of intervention for the lesion. So the reduction of the restenosis, reduction the risk of restenosis is primary target for this patient. In that point, actually, the Peri-stent staining must be treated in this patient. This is contained rupture, most likely end up with pseudo aneurysm.
Yes.
There is no shock during the procedure, and you implant the graft stent, it will increase the risk of restenosis.
Yes.
My question is that the graft stent really necessary in this situation?
Yeah, thank you for your important question. Yes, we discussed a lot of time about this, about your question as well. Well, we wanted to prevent the coronary aneurysm at the ostium site, but as you said, it means that the risk of restenosis increase dramatically. So we have to use more strong DAPT or something. But and we also thought the CBZ is necessary as well, but she already underwent twice, so third times third times operation is not good, of course. So yeah, we have to follow up this lesion.
I think it might be left alone without further risk. And Lima to LAD is the functional in this patient?
Yes, we thought so.
In that case, actually, fate of the osteals after vein graft is not so important for this patient.
Yeah, thank you for your question.
Go ahead.
Okay, so maybe we go to the next speaker in the interest of time. So our next speaker is Dr. Ahmed Adel Shaheen from Loran Hospital, Egypt. And the topic is left main artery thrombus treated with eluting stent. Dr. Shaheen, please.
So I would like firstly to thank everyone who gave me opportunity to present this case in such mega events. Without any further ado, I'm going to present this case. It's left main artery thrombus treated with drug eluting stent. This is 75 years old male with type 2 diabetes, hypertension, heavy smoker, dyslipidemic, presented with typical chest pain associated with sweating and excessive vomiting for 6 hours. Patient was transferred to a district hospital, which was PCI non-capable hospital. In emergency, patient crashed and his blood pressure became unrecorded. Prompt transferring to our hospital ICU 6 hours after chest pain. Vasopressor was given at maximum dose, but blood pressure of the patient was still unrecorded, however. Patient then has been intubated and kept on mechanical ventilation. His ECG showed ST elevation in 1 AVL and from V2 to V6 with right bundle branch block. Bedside echo showed severe anterior anterolateral apical septal hypokinesis. Ejection fraction was around 10 to 15%. Patient then arrested in VF. Cardiopulmonary resuscitation was started immediately. And thankfully, restoration of spontaneous circulation after 4 cycles of CPR. At that time, ICU team activated cath lab at 3 a.m. So I have discussed with his relative, his daughter is a physician. She is ICU specialist. And I discussed the futility of the patient with her and how long the time of hemodynamically instability and how much myocardium had been jeopardized by this cardiogenic shock. But she asked me to give him a chance. So our summary for this patient, he is old patient with multiple comorbidities, presented relatively late in a cardiogenic shock, post-arrest due to STEMI, which would be left main versus multivessel disease. But unfortunately, there was no mechanical circulatory support available in our center at that time. This is the first shot. Jatkin left was engaged in the left main. And this is actually the first shot showed only small stamp of left main, and there is no runoff. This is the second, immediately engaged with XP 3.5 guiding catheter and 0.014 workhorse wire was negotiated in the ramus. But again, there is no any distal flow. I used the small 2.0 by 15 ballooning and just dottering in and out to create any distal flow, and this is after dottering showed significant diffusely diseased vessel with left main thrombus containing lesion. I would say Medina 110. I would say that the ostium of the left circumflex is relatively healthy, given that hemodynamically instability of the patient with this left circumflex ostium is healthy. So our decision was to do provisional stenting to make the procedure much more easier and fast. And then pre-dilatation using 2O by 15. And then 2 workhorse wire were secured in the left circumflex and the left LAD. Then this is LAO cranial. This is very important view to implant the left main stent with a very minimal protrusion in the aorta to cover the roof of the left main. This is 3 actually, 3 by 28, 3O by 28 designs. And this is implantation of the stent. And this is after implantation of the stent. And then post dilatation. This is a stent post show how discrepancy between the proximal LAD diameter and the distal left main. Then again, post dilatation. And this is final pot using 3.5 by 15 up to 22 atmosphere. And unfortunately, at that time, the no reflow became prominent, as you see, even the staining of the descending aorta. And then, as this is very horrible view actually, all the descending aorta is full of contrast. And then the patient arrested, unfortunately. CPR was started immediately, and this is after the patient restored his spontaneous circulation. And this is the final shot for right coronary artery with mid significant lesion. This is pre and this is post. This is pre and post intervention. So our take-home message is ST elevation myocardial infarction involving left main coronary artery has been associated with significant morbidity and mortality. And most studies are limited by small sample size. That's because many cases are never reported because of pre-hospital death. Again, provisional stenting still a relatively fast and safe technique in a primary left main PCI. Early using of mechanical circulatory support instead of escalating the dose of inotropes and vasopressor may avoid the downward spiral in a patient with cardiogenic shock and resulting in a high mortality rate. Thank you very much.
Thank you, Dr. Shaheen, for your excellent case presentation. So any questions from the floor?
Yes.
Sorry, please go ahead.
Okay. Right. Yeah, this is Dr. Mohsin from Bangladesh. I have a question to Dr. Ahmed. Could you have considered a mechanical thrombosuction instead of daughtering with a small balloon, because it can push the thrombus downstream and cause more problem?
Yeah, this is very good point, but you know, our thrombus in the left main. So I was not scared about left main because already we have a thrombus in left main, and I was just make daughtering to see the distal flow. Just if I was seeing any heavy thrombus burden, I would have been used thrombosuction. But at that time, I appreciate that the thrombus is gone and there is tight lesion in distal left main. I prefer to just dilate the distal left main and then see what next.
Can I ask? I think the quick recanalization is very good. That helped this patient. But the problem next comes was that the distal embolization that caused no flow. So can you use a distal protection device in your country, in your hospital?
Thank you very much. I would say that distal embolization is not frequently used in our country, but again, even guideline is not recommended that distal embolization in a native vessel, except for SVG. And I don't think about using it, actually, to be honest. I didn't use it in a native vessel at all.
The frequency is low, but it sometimes happens and result in this kind of cases. So if you can check by IVAS or evaluate the risk of their distal embolization, I think for the selected patients, distal protection device is very good. Thank you.
Yeah, I totally agree.
Actually, I think we should stop just after the ballooning. I mean, everyone knows that the flow is more important than the residual stenosis, especially in this patient. So actually, just after ballooning, we see some slow flow. If they put the stent there, the no flow is inevitable. So maybe without MCS support, maybe you can stop just after ballooning, and after patient recovers, the delayed stenting may be working. Anyway, this patient is quite critically severe disease, so very little chance to survive, actually. Okay.
Actually, yeah, I totally agree with you. But actually, I was very enthusiastic when I make adjusted dottering and I see distal flow is not bad. So the only thing I would be reluctant not to do it is a pulse dilatation with 3.5 by up to 22. At that time, the no reflow is increasing. That's why I think distal embolization increase with significant pots.
Slow flow even after the ballooning, actually. Okay, Dr. Chen, go ahead.
Okay, so we have to go ahead despite our hot discussion because the time is limited. So our third speaker is Dr. Kunwi Ko from Penang General Hospital, Malaysia. And Dr. Ko will talk us about the culprit confusion during primary PCI. Do you touch the CTO? Dr. Ko, please.
Very good morning and good afternoon to everyone. I'm Kwei. I'm from Penang General Hospital, Malaysia. It's a great pleasure to me to present a case in TCTAP. So the title of my case is Culprit Confusion During Primary PCI. Do you touch the CTO? Okay, I have no conflict of interest. So our patient is a 33-year-old lady. She has history of stroke with right-sided hemiparesis 3 years ago. She presented with an acute chest pain associated with sweating for 1 hour, went to a district hospital with no PCI facilities. Upon arrival there, her vital sign is relatively stable. So ECG done there showed ST elevation at lead 1, AVL, V2 with reciprocal changes at the inferior leads. So immediately diagnosis of acute lateral MI was made, and the medical officer there activated our Penang STEMI network, referred to us for primary PCI. Upon arrival to our hospital, her vital sign was stable and she was directly brought to CAT. So we chose to use a right radial access, 6 French shift, and a 5 French diagnostic catheter. So this is the angiogram of the left system, showed the occluded mid-LAD. So another spider view, occluded mid-LAD, no significant lesion at the left circumflex. This is another view. So angiogram of the right side showed a smooth right coronary artery. So in short, this patient is having a single vessel disease with occluded mid-LAD. So we plan for primary PCI to the mid-LAD. However, during insertion of the guiding catheter, the patient developed a radial artery spasm. So we convert to a right femoral access, use a 6 French shift, and a guiding catheter exhibit LAD 6 French. So without much difficulty, actually we are able to cross the occluded lesion with our run-through floppy wire, workhorse wire, and subsequently pre-dilate with a 2O semi-compliant balloon, and stented with a 3O drug eluting stents, and finally post-dilate with a 3O NC balloon. Okay, this is the final result. We are able to achieve a TMIX from 0 to TMI 3, EMPG grade 3. Patient also no more chest pain, and from the angiogram, there's no complication. We are quite happy with the final result. So before we bring the patient out from cath lab, we ask our consultant to have a final look at the images. Somehow my consultant is not very happy with the final results. Okay, especially from this spider view. He said something is not right. Okay, he told us the direction of the LAD is very unusual. Is this a true LAD? Are we in a true LAD? So since there's a doubt, he decided to puncture the left femoral artery to give a contralateral contrast injection. Okay, so this is a contralateral injection. So very true enough, there's a retrograde flow from the RCA towards the true LAD. So what we have standard earlier is actually from proximal LAD to the diagonal branch. So it is a CTO LAD. Okay. So what actually patient is having is actually she has an acute occlusion of the diagonal and at the same time concomitant mid CTO mid LAD. So this is actually tally with her ECG when she presented with a lateral MI. So at this moment, we have already stented the culprit artery into the diagonal branch. And what should we do next with the CTO mid LAD? Should we stage the CTO LAD later in a later date? Or should we just try to open up the CTO LAD now? Or we just leave it medical therapy? Okay, so after taking consideration that the patient is very young and also the stented part is still very new, so we decided to attempt to open the CTO. So we start with a feudal XCR wire. After 5 minutes of attempting, we are very lucky enough to be able to cross the CTO. Okay. After crossing the CTO, we give a contralateral injection to make sure that we are in the true LAD true lumen. So subsequently, we pre-dilate the CTO with a 2O semi-compliant balloon. And then after that, we're happy with the pre-dilatation. We stented with a drug-eluting stent 3O stent size through the Culprit technique. Then post-dilated the both LAD stents and the diagonal stents sequentially with a 3O NC balloon. So finally, we did a final kissing balloon inflation with a 3O NC balloon at both stents. And this is the final result. We're able to achieve a TME3 flow at both LAD and diagonal artery. So the total procedure took 90 minutes, total contrast volume 250 cc. Patient was well and discharged after 5 days. We managed to get an echo before patient discharge. The EF was 55%, hypokinesia anteroseptal and anterolateral wall. So from this case, I have learned a few learning points. First of all, clinical correlation with ECG and coronary angiogram is very important. So we should have high index of suspicions whenever coronary angiogram showed an unusual artery cause. So multiple views should be done whenever there is doubt. So for example, this patient, we would have missed the CTO LAD if we are not careful enough. So last but not least, treating a CTO during STEMI can be challenging, and it is feasible in selected group of patients, provided that patient is hemodynamically stable and also the operator is experienced in doing PCI to CTO. With this, I thank you.
Okay, thank you. Any questions from the panelists?
Yes. Can you be sure that the totally occluded LAD is CTO lesion? Can it be the culprit of acute MI? If you cannot be sure that it is the CTO lesion, it is very good to try to open it up.
Yes, true. This is true.
How do you think about this case?
Oh, during that time, because after
you
open
really
the diagonal, from the feeling of the when we try to wire, after 5 minutes only able, so we think that it's a CTO, and then with the ECG changes as well, and clinically patient also no more chest pain after we wire down to the diagonal branch, because initially we thought job done. Once a wire down, no more chest pain. With this, we expect if a mid LAD, we should expect ECG changes all the anterior leads as well.
Dr. Cole, do you have a chance to do echo before this PCI? Is the anterior wall moving?
Oh no, because this is a primary PCI transfer from other hospital directly to our lab. So we never did a pre-PCI echocardiogram.
Okay. Okay, if no, then shall we go ahead, Dr. Kwong?
Yeah, I will introduce the next 3 speakers. Next speaker is Dr. Davinder Singh Chadha from Manipal Hospital, India. He will discuss about the novel snare-assisted retrieval of embolized percutaneous aortic valve and completion of the procedure.
Yeah, I bring you greetings from India. Thank you for giving me an opportunity to present a case of transcatheter heart valve embolization. My patient was a 65-year-old male hypertensive who had CKD with creatinine levels of 1.6. He had degenerative aortic valve disease with severe AS and severe LV systolic dysfunction and LV EF of 25%. He had presented in heart failure in NYHA class 3. So we went ahead, this was in the September 2017, we went ahead and did the balloon dilatation for him because we did not find him fit enough for TAVI straight away. And we brought him back. We brought him back, the balloon TAVI with 1640, and we brought him back after 6 months. And by this time he had become class 2. He was walking about 3 kilometers and he had reached the functional class 2. So based on the CT scan details, we selected 26 millimeter Evolute R valve for him. And we planned the procedure. We went ahead, since it was a bicuspid aortic valve, we dilated the annulus again, and we placed the prosthetic valve. And everything looked to be smooth. Sorry, this is not playing. Now it's playing. So we thought we are at the right depth. We went ahead. We started deploying. Everything looked okay with the pigtail catheter showing with periodic puffs. And this was the implant going on. And this is how it looked post-implant. And to our surprise, it did not last for very long, and the valve moved back and it embolized. The moment it embolized, we had to put a snare from the left femoral artery. We held it in place. The central wire was within the lumen, and we thought that we are holding it with the snare, so we'll be able to place another valve. So valve stabilized in the ascending aorta post-embolization. The confida wire, which was in the LV, was pretty stable. We took another valve, and we thought we are now will be able to position. So the moment we pushed the second valve in place, it would not let the embolized valve stay in the ascending aorta and would move it down. And we were not too happy implanting it here because that would have led to formation of a tube graft covering both the coronaries. So we had to do something more. So what we did was we took an additional radial as well as an additional femoral puncture, and through the femoral puncture, we put another loops snare, and we took a JR guide and put this JR guide through the stent struts, and looping a thermo wire, we snared it out of the femoral through the radial artery. So now we had a loop snare made out of the radial guiding catheter and the thermo wire going out, and which was snared through the radial artery, and a loop snare from the left femoral artery holding the device in place. So these were the snares. We had a loop snare from the left femoral artery. We had a JR guide thermo wire through the left femoral artery, an additional snare holding this thermo wire from the left radial artery, and a confida wire. Now, in the lumen, so we had four arterial punches. Now the valve had stabilized, and we took the second valve and we released the JR loop snare. By this time, the embolized valve had stabilized in the ascending aorta, and we were absolutely comfortably able to deliver this second valve into the aortic position. The valve was placed, and we put a pigtail. We took out the JR guide and replaced it with the pigtail, and we positioned the valve in the annulus correctly this time, and we upsized this time, and we took a 29 millimeter valve. We had previously implanted 26, which had embolized. So this is how it looks post the second valve. When we did a pigtail shoot, we noticed that there was nearly moderate AR which was present. So we put a wire and did the balloon dilatation, and there was considerable reduction in the quantum of the paravalvular leak which was present. Now this was essentially because this was a very calcified valve. So valve embolization is one of the rare but potentially fatal complications, and the registry data reports about 0.3 to 1.1% of patients having. It's more common with the inexperienced operator, and is seen with different both types of valves, and especially those who do not follow the protocols of valve implantation. It's the balloon mounted valve which embolize majorly, because the self-deploying valve, you can reposition, recapture, so that function really helps you to prevent this. And the access site in majority has 90%, more than 95% are transfemoral valve implantation. So majority of patients had transfemoral deployment of these valves. They can occur as early as less than 1 hour and can be delayed between 4 hours to 43 days. The most common site is the ascending aorta or the left ventricle. Descending aorta is about 23%. Aortic arch in about 8%. The likely cause of the embolization is positioning error, pacing errors, as well as undersizing. In our case, it was the undersizing of the valve which contributed to its valve embolization. So accurate sizing of the aortic annulus is really, really important. And it is advisable that we normally do a 10 to 15% oversizing, and this is primarily done to prevent PVL. And now we have the Evolute Pro available with an additional skirt which prevents the PVL. Now, what are the complications? It can cause arterial embolization. Strokes have been noted in about 11% of patients. It can cause renal failure because you tend to use a lot of contrast, and most of these patients have a lot of comorbidities. It can cause coronary ischemia if the skirt covers the coronary artery. Well, in our patient, none of these complications are noted. So my take-home message is meticulous assessment of the coronary and aortic anatomy is very, very important, and this will lead to a successful procedure. All the hardware listed in the procedure should be available in the shelf. Now, this is really, really important. If snares are required and if additional tools are required, everything should be there on the table because you never know when the lightning is going to strike. And yes, innovations are required in CCL. We innovated by putting a JR guide and a loop snare made out of the thermo wire, which was used to stabilize, but nothing should be done at the cost of patient safety. Thank you so much for your patient hearing.
Thank you, Dr. Chada, for sharing the very complicated procedures. So any questions and comments from the panels and audiences?
Yes, please.
Okay, go ahead.
Yeah. Thank you for your good case and a great presentation. And may I ask some questions, please? Do you show the CT analysis for this case?
Did you?
Because could you please show the CT analysis? How about the annular size and anything, please?
Correct.
Because I think valve size is okay. I think it's not cause the valve embolization.
No, valve size.
I
have the detailed CT because the presentation was for 4 minutes, so I skipped it. And if you want, I can open and show you the details of the CT because I will be able to, in a minute. If you
don't have enough time to do so.
So I mean, it was 10% oversized. The valve was 10% oversized. It wasn't undersized. The perimeter, we used the perimeter selected diameter, and I will just give me 1 second. I'll be able to tell you what the perimeter was. I will just 1 second. I'll just go down.
So your intended oversizing is a 10% using the 26 millimeter cold
yes,
valve. Is that right?
Yes, correct. So the minimum diameter was 20 millimeters, maximum was 25.9, perimeter was 72.9. On the sinus of Valsalva was absolutely normal. The LVOT minimum was 13.9 and maximum 24.4. Ascending aorta dimensions were more than 30 millimeters. There was considerable valvular calcification, which was noted. And the sinotubular junction minimum was 29.8 and maximum was 30. The sinus heights of both the coronaries, everything was absolutely normal. And the annular angulation was about 39 degrees. This is what was the CT finding in this case.
And also from this analysis, I think that valve size, first valve size is 26, right?
Yes.
I think it's the proper size for this case. But yes. I think because of the valve embolization may be caused by the nose cone from the final release. After final release, nose cone catch up the tip of valve, pull up the valve.
I showed you the valve in the final view. You saw the wire was inside, the nose cone was in the LV, and then there was a absolute slow migration of popping out of the valve. And there was so much of calcium, we did not expect this to happen because we had oversized by more than 10%. And then there was calcium, we thought it's going to stay stable, but it just popped out and we were surprised. And now since we had to do something, so we were not able to hold this valve in position. So we had to design a loop snare using a JR catheter, which went through the open cells of the proximal, the outflow tract of the valve. And we held it in place and we upsized it by one size. So we took a 29 and deployed that, and which stayed in position.
So very interesting discussion, and we for the time constraint, so we need to move to next presentation. Next present is Dr. Woksakong Luang Piba. Is that right? From Central Chest Institute from Thailand. We'll talk about the uncommon GLY complication. Go ahead, please.
Good morning, everybody. My name is Woksakong from Central Chest Institute of Thailand. It's my pleasure to present this case named uncommon GLY complication. I do not have any disclosure. A 45-year-old Thai male, ex-smoker, hypertension, dyslipidemia. He was referred with inferior wall STEMI 9 months ago. He was diagnosed triple vessel disease with previously performed primary PCI to RCA and PCI to left circumflex. Echocardiography showed normal range of LV function. Laboratory was normal. The control angiogram showed good patency of previous stent in both RCA and left circumflex. You can appreciate that LAD show diffuse lesion from proximal to mid-segment with a tight lesion at very proximal DG1. So our targets are LAD and DG1. The strategy of our PCI is to stent crossover DG1 bifurcation. So we put two guide wires. Then we dilated DG1. A stent was deployed at proximal DG1 without difficulty. Next, mid-LAD was dilated, and a 2.5 by 18 millimeter stent was deployed. Then we dilated mid to ostial LAD. Then a 30 by 34 millimeter stent was deployed at ostial to proximal LAD to overlap with the stent at mid-LAD. This is the angiogram after the last stent. Show good flow in both main branch and side branch. The procedure seems to straightforward, but when we try to remove the side branch wire, the wire was stuck. Now our problem is entrapped guide wire in the side branch. How should I do? At first, we used like microcatheter fly cross, but it could not remove this guide wire. Even it went into the part of the stent. Even we tried the smallest balloon, 1-0, but still could not work. Then we use another 2-0 balloon to anchor at LAD and try to push the SC balloon underneath the stent, but unsuccessful as well. So we changed to Corsair. At that time, I hope the screw property, but it could not drill this microcatheter to DG. So we chose Tonus. We hope that its stiffer tip could work, but it failed again. After many attempts and devices, a stent would show that the proximal part of the stent was severely deformed. Yeah. So now we got more problems now. After discuss with our team, we plan to what retrieval devices should I use? After I consult my senior staff and extensive review all the angiogram, we realized that the mechanism of the guide wire entrapment was as shown in the picture. The wire formed a loop around the stent before it was deployed. When we try to pull out the wire, the lasso formed over the side branch wire caused stent distortion as a tight lacing corset. If we use a small balloon to inflate inside the distorted stent as a core to counter while pulling the lasso wire loop, they will form a combination that will strongly grasp the distorted stent. We hope that this method could help us pull everything out all together. So at the time, we put 2 O balloons in the distorted stent, then inflate and try to pull out both balloon and side branch wire all together. We tried so many attempts of this method, as well as replace the operators who dare to pull it, but it's still unable to retrieve the stent. But at last attempt, after maintaining the pulling force for more than 20 seconds, the wire gradually free out of the sideband successfully. This picture shows guide wire was completely removed and the shaft about 4 to 6 centimeters show kinking, which resemble the lasso part of the stent. We recheck angiogram after wire removal. Luckily, there was no any perforation or dissection. It is the IWAS shows severe stent distortion with malapposition at ostial to proximal LAD. After that, 4O by 22 millimeter stent was deployed to cover the damaged part of the previous stent. This is the final IWAS show good stent apposition. This is the final angiogram. Take home message. Beware the angle and curve of the wire at the lesion site after balloon and before stenting. If in doubt, do not pull the gel sideband wire forcefully because the wire may fracture and it causes the damage, the stent as shown in our case. A small balloon inflated inside the distorted stent as a core, plus forcefully pulling of lasso wire loop, equal a strong combination to grasp the stent. I acknowledge all my mentors in Central Chest Institute of Thailand. Thank you for your attention.
Thank you for sharing the great case. Actually, can you give me the name of the wire and stent again?
Oh, sure. The wire that, a minute please. Okay. I have 2 wire, yeah. The wire in the side branch is Hyeon-Cheol. Yeah. A minute. Yeah. The wire in the EG1 is Hyeon-Cheol. Yeah. And the wire is in the distal LAD that used in the LAD is Hyeon blue.
Okay. And the stent was?
As the stent was Resolute Onyx.
Onyx. Okay.
Onyx.
Yeah. Any comments and questions? So it might be a kind of a crush technique without removing the wire from the side branch. So that might be the cause actually. But during the cross technique, you should remove the wire and blow everything out of the side branch. It might be that.
First before deploy the stent, right?
Right. Yeah. Maybe the stenting, the wire and everything must be removed. It's just like a cross technique. It looks like a cross technique.
Oh, thank you. But it is my own fault that I didn't beware of the wire in the side branch, and I deploy the stent in the main band with like 15 ATM.
Anyway, the actually wires are stuck between the 2 stents, 2 metals, very, very powerful. And without the stent, the compression actually you can manage with Corsair and the 1.5 balloon, but the wires between the 2 stents is very difficult to remove. That's why we remove the wire before the cross technique.
Okay, thank you.
Maybe I think so. Any more questions? Okay, I'd like to introduce the last speaker, the Dr. Karthik Laguram from Sri Chitra Trivandrum Institute of Medical Science and Technology, India. He will talk about the Trans-Catheter out valve replacement in the presence of Starr-Edward prosthesis, the mitral position. It will be a great presentation. Go ahead, please.
Good afternoon, respected panelists and moderators. My name is Dr. Karthik Laguram. I'm Senior Resident in the Department of Cardiology in Sri Chitra Trivandrum Institute of Medical Science and Technology, India. I'll be presenting a case of a transcatheter aortic valve replacement in the presence of a Starr-Edward processes in mitral position using a balloon expandable processes. I'll be stressing upon the technical challenges and how we managed. I have no disclosures. The case is that of a 71-year-old gentleman who was diagnosed with rheumatic heart disease with severe mitral stenosis and underwent mitral valve replacement with a 28mm Starr-Edward process at a center in 2004. He was on regular follow-up with NYHA function class 1 up to 2019 when he noted increasing dyspnea on exertion and recurrent admissions for heart failure. He was evaluated and was diagnosed with severe aortic stenosis. A coronary angiogram done at that time revealed normal coronaries. The STS score for this patient was more than 8%, and the Euro 2 score was 13.9%. He was considered high risk for surgical aortic valve replacement and was planned for TAVR. The ECG for our patient showed atrial fibrillation with a rate of 70 per minute and left ventricular hypertrophy. Chest X-ray showed cardiothoracic ratio of 0.5, grade 1 pulmonary venous hypertension, and Starr-Edward processes can be seen in the mitral position. Echocardiography revealed a normal ejection fraction, LV ejection fraction, severe aortic stenosis with a mean gradient of 76 millimeters of mercury, mild aortic regurgitation, and mildly elevated transmitral gradient, the mean gradient of 8 millimeters of mercury, and severe pulmonary arterial hypertension. CT evaluation for this patient was done, and it revealed aortic annular dimension of 22.2 millimeters, LVOT dimension of 22.7 millimeters. The right coronary and left coronary height were adequate. The aortic dimensions were adequate for procedure, and the access site dimensions were also found to be adequate. The mitral aortic distance in this patient, as measured by CT, was 5.5 millimeters, the importance of which I'll be showing later. The procedure was done with a general anesthesia and a transesophageal echocardiography guidance. Transfemoral venous access was taken and pacing lead was placed in the RV. Pigtail catheter angiogram of the aortic root was taken in the anterior posterior view and iliocranial view to assess the aortic valve and mitral valve. The aortic valve is calcified and with restricted opening, and the mitral valve function looks normal with no mitral regurgitation. There is mild AR. The basal pressures and the basal gradient was 70 millimeters of mercury. The aortic valve was crossed with a 0.035 straight wire, and balloon valvoplasty in our patient was done using the same balloon of the delivery system, which was a navigator balloon and with a dimension of 21.5 millimeters. This was done to assess any interaction between the balloon and the mitral processes prior to actual valve deployment. This is essential in this kind of patient. A 23 millimeter MI valve, manufactured by Merrill Life Sciences India, was positioned at the aortic valve with the implantation ratio of 80-20. The valve was deployed with rapid ventricular pacing. Post-deployment aortic root angiogram shows good expansion and placement of the aortic processes with trivial aortic regurgitation and no mitral regurgitation. Post-procedure, there was no gradient between the LV and aorta. The possibility of interference between the two valves, which can affect deployment of aortic processes or normal function of the mitral process, should always be considered in these kind of patients. The aortic processes may not expand fully and may get deformed because of the rigid mitral annulus. In the case of a balloon expandable valve, the balloon can meliscede into the aorta during expansion, resulting in embolization of the prosthetic valve. The mitral aortic distance is of paramount importance in this patient. A distance of more than 5 millimeters is considered adequate, and this can be accurately measured by CT angiography. The risk is greater in the case of a Starr-Edward process in the mitral position, as a bulky cage projects into the outflow of the left ventricle. A high implantation with a ratio of 80-20 compared to 70-30 regular cases helps further mitigate interaction between the mitral processes and the TAVI valve. And in this case, especially, we used a delivery system balloon that was a navigator balloon for balloon valvoplasty, and which helps accurately observe balloon expansion and assess whether there's any balloon shift and interaction between the balloon and the mitral valve processes. In conclusion, the technical challenges in this case and management are as follows. The high possibility of interference between Starr-Edward's mitral valve process and TAVR processes should always be considered. An accurate assessment of the mitral aortic distance by CT is essential. High implantation of 80-20 helps further mitigate possibility of interference between the Starr-Edwards and the TAVR processes. And the use of a balloon valvoplasty using the same delivery system balloon to assess possible interaction between the mitral prosthetic valve and the TAVI valve prior to deployment is essential. Therefore, a comprehensive evaluation of the patient can successfully overcome the technical challenges for TAVR with balloon expandable processes in patients with Starr-Edward's mitral valve processes. Thank you.
Thank you for a nice presentation. Fortunately, there was no interaction between the Tabby valve and the Starr-Edward's valve in mitral position. So any question and comments?
Yes, this is from Dr. Mohsin. Actually, the literature for the TAVR is mostly for degenerative valve disease. But in this case, there was an implantation for a rheumatic valvular disease where there is a lot of commissural fusion. So what's your, what is the long-term follow-up of the patient and how the patient is faring, because there is under expansion of the valve is very likely, or there is a long-term problem with the prosthetic valve in a rheumatic etiology background?
Yes, I agree with you. Currently, the patient is on follow-up with function class 1. There is no new aortic regurgitation, and the valve gradients are still normal. So it is still, the outcomes are actually good in our patient.
So when was the mitral valve prosthesis was implanted in this patient? How many years ago?
It was in 2004. That's almost 16 years back, sir.
So how old is this patient?
Patient is currently 71 years.
So might be degenerate in the background of a rheumatic disease. Okay. So
yes, sir.
One more question and comments. One more, just one more. Okay, so actually echo and the CT scan could tell us that what is the fate of interaction between two valves. So can you see that in the CT or echo?
You mean the after the valve deployment, sir?
In the planning of the procedure, maybe echo and CT could have showed us the result.
Actually, there is a CT image that I had shown. The possibility of interaction, first the mitral aortic distance.
Okay.
This distance is very important, especially in these kind of cases, because the cage distance from the aortic valve with less than 5 millimeters, there's high chance of interaction between these two valves.
Okay, this is just maybe the key picture of this procedure. Thank you for showing nice cases. So,
thank you.
Okay, Dr. Chen, can you wrap up this session for us?
Okay, thank you, Dr. Kong. So, so in this section, we have 6 cases presented, all very nice, and we learned a lot from all these 6 cases. So I'd like to thank the co-moderator, the panelists, and all the speakers. So thank you very much.
Thank you. Thank you, everyone.
Thank you.
Thank you.